everybody. My name is Thomas Gehring from Piedmont Heart Institute in Atlanta, Georgia. And today I have the great opportunity to be here with my friend, Dr. Paul Wang, who is the Chief of Cardiac Electrophysiology at Stanford University in Palo Alto, California. We are here at the annual Piedmont, Stanford, Cleveland Clinic conference here at Napa Valley, and I have a great opportunity here to pick the brain of one of our great leaders in the field of electrophysiology on topics relevant to atrial fibrillation, and ideally those things that are related to reducing the thromboembolic risk of atrial fibrillation. Paul, thank you for joining me here. I'm glad to have you. Maybe if you could just give us a little background on what you think is the issue related to the thromboembolic risk in atrial fibrillation, and then we'll get into some of the new technologies that are there.
Yeah, it's terrific. It's great to be here, Tom, and share this important topic with you. I think we're so excited at this point in the field that we have so much focus on prevention of stroke and atrial fibrillation. As you know, stroke and atrial fibrillation is one of the most important and really factors that lead to poor outcomes. So it's very timely that we talk about this and focus on what's new in that area. Some of the big advances in our field relate to the development of non-vitamin K dependent oral anticoagulants. So this has really allowed a whole number of people who I think have been adverse to anticoagulation in the past, largely for convenience sake, for the situation of warfarin-related drug interactions, food interactions. And so a whole number of patients now I think are very willing and interested in really having a concerted effort to reduce the risk of stroke and atrial fibrillation, taking these oral anticoagulants. So I think we have a really promising future of making a serious impact in a very debilitating illness, stroke, in the setting of atrial fibrillation. So I think that's one of the first things that I would want to talk about. I think next really we would really look at the factors of the novel anticoagulants, and in particular the fact that we have some new developments. For example, we have the first agents that are now available to reverse the effects of these new agents. There's always been a concern, and when they were first introduced, well, we don't have the same ability to reverse anticoagulation as we can for warfarin. We've obviously had warfarin for decades and know very well how to acutely reverse them. So that's been a concern of many patients. So I think we can be very reassuring to those patients that we have some of our first agents, though agents that are able to reverse the anticoagulation effects. So I think it's another major advance. In addition to that, we're gaining more scientific knowledge about the overall impact, why in some settings there might be a higher risk of gastrointestinal bleeding, what the overall risk of hemorrhagic stroke may be. So an ongoing body of literature is being developed to really inform us about the relative risk of each of these agents. So I think there's more to come in terms of learning about that, but I think the take-home message is that this is really great news. We have really important news to deliver, that these should be a part of our daily practice. And as you know, I think our field has embraced these new agents, and I think they play an important role in the overall therapy.
That's very helpful, Paul. Clearly there have been some major trials looking at the use of the novel or the new oral anticoagulants, and the guidelines from our societies have followed forward with recommendations as to how we should perhaps use them in our population of patients and individually with patients realizing there are differences. In your practice, how do you see them presently serving a role in the treatment of different patients, given the traditional warfarin that we have and the newer agents? How do you clinically, when you're sitting in front of a patient, make a decision to go in this direction or that direction? And what are the rate limiting steps that make you move more towards one or the other end?
So I think the first thing that we've learned, and really our societies in the United States have really adopted, are the criteria first for anticoagulation. So I think that's the first starting point, and that's where we start with patients, as you know. First is to define the overall risk for each patient, and then really to come together with a strategy for that patient. Is oral anticoagulation appropriate? Are there individuals who it's not appropriate for therapy? And now as all of our practices use the CHADS-2 VAS scoring system, that ability to be able to readily score patients and in a single visit be able to say, yes, I think this is the reason I'm recommending anticoagulation for you. I think that's well received by the patient. I think they feel that we have a quantitative way to address that issue. I think that's helpful, and I think allows us to have some degree of really guidance and precision in individualizing the therapy, which is quite important. So I think that's some of the biggest issues. We obviously don't have a scoring system that says, oh, this specific agent should be used versus another. That's currently not available, but yet we have general principles for the use of anticoagulation. So I think that's one of the most important things. And as we learn more and there's more data that are available, I'm sure we'll have more of a nuanced precision of which agent specifically to use.
No, I think that is very, very helpful. You know, clearly there are advantages of the newer agents compared to the traditional warfarin. You know, the ease of compliance, not having to have your INR checked regularly, the ability to not have to modify your diet as much. One of the probably concerns on a number of patients is the economic implications thereof. How do you address that with your patient population?
Yes, that's a great question. So it's a real practical issue, of course. Obviously, that's an area of great individualization. We've seen great variation in the different markets, the payer distribution in terms of the coverage that they have, and the amount of reimbursement. Frankly, there's been a lot of, I think, variability. Luckily, for most individuals, there are reasonable options that are available, but that is very dependent on the individual and their individual financial circumstances, what's available. Clearly, for most individuals, warfarin is still economically feasible. So I think, though it's a major factor, I think the key issue for us is to have them on some form of anticoagulation. If I could interject, I think one of the biggest challenges, frankly, is not after the patient agrees to have anticoagulant therapy. That is, I think our compliance is actually quite good, and there's now some excellent studies that have looked at that, saying that once patients agree to take anticoagulants, their overall compliance is probably, and adherence to taking these medications is probably over 70%, which for various medications is quite good, particularly for an asymptomatic condition. So overall, I think adherence, once it's accepted, is in fact quite high. What I find most challenging in my practice is that I don't even get acceptance. Many patients will look me in the eye and say, no, doctor, I understand what you're saying, I understand that I'm at high risk, but I refuse to be on these anticoagulants. And so I think that's one of the biggest challenges in our field we face, and a very practical one in our daily practice. That we really don't know how, and perhaps it's a communication issue, perhaps there's a way in which we need to understand better how to really connect with the patient in such a way. But this happens to me every day, and I think that's one of the more challenging aspects of really prescribing and managing for these patients.
I think you make a very good point, Paul. You know, a less important question is which drug you use. A more important question is that you identify the risk and then be able to hopefully encourage the patient to take that medication. I find a lot that patients have fears that are based on bleeding risk. They had a family member, or they heard about someone, or they've seen ads on TV. So being able to upfront, frankly, address that with the patients and try to put it in perspective on what the true risk is and what the implications of each are, I find, you know, actually to be very, very helpful. But globally, as we know, only somewhere between 40 and 60% of patients who meet guideline-directed criteria for utilization actually get the drug. So I think it does take time with the patient, and you need a system in place to be able to communicate about what are those, you know, rate-limiting concerns. I don't know what your thoughts are.
Great. I think you hit the nail on the head. I mean, I think exactly understanding that where the patient's coming from, that's always I think the secret in clinical medicine, is really acknowledging the patient's own perceptions, where their feelings come from. As you said, it's often very personal, whether it's based on personal history or the impact it's going to have on their perceived quality of life. Those are the issues that always come to the fore, but they may not be spoken. And I think addressing those really up front is a really important strategy, one that we really hope in our practice to really focus on and find ways to really go through, because it's extraordinary where, as you said, the numbers are staggering. To think that we have treatments that significantly reduce the risk of stroke and have, you know, taken years and years and huge amounts of resources, and yet half the patients don't get that benefit. That's an extraordinary finding. And so I think to be able to counter that is really important.
Thank you, Paul. Let's segue into some of the other new options we have for trying to reduce the risk. We know that there is a device recently released that can be percutaneously inserted into a heart to minimize the risk of thromboembolic events, the Watchman. Could you tell us a little bit about, the studies that supported the use thereof and, where you see it presently in practice?
Sure, that's great. I really appreciate that opportunity. I think what we have is really unprecedented because now we have a non-pharmacologic strategy that can really potentially reduce the risk of stroke in patients with atrial fibrillation. So that's a major advance in my opinion. Now, because of our regulatory system, it's taken quite a while for this device to make it to clinical practice. And then beyond that, the hurdles of reimbursement, et cetera. But I think the key point is that yes, for patients that really have contraindications to anticoagulation, this is an extraordinary option for them because we just haven't had this to this point. And I think in many ways the regulatory challenges have allowed us to learn more about the use of this device. It's allowed us to understand what the learning curve is, that there is a learning curve, that's the ability to perform the procedure safely is really very important in overall outcomes. But I think the key thing is that we now have a non-pharmacological solution. So I think for the future, I think it's really bright in terms of looking at these. There's a whole series of other so-called follow-on devices that will perform similar functions that are in clinical evaluation now, will eventually get regulatory approval, I'm sure, and will, I'm sure, fill in the gaps in terms of what we have and address some of the issues with current devices. So, but I think overall we're quite excited about that. Again, we're in a stage where a newly approved device in the United States, we need more comparison randomized trial data. And I know all of the federal regulatory agencies and in fact are looking at that. The reimbursement obviously has been something that's watched very carefully. The current reimbursement is really for patients who aren't not able to take oral anticoagulant, and that's, I think, a little more narrowed than the original FDA approval language. So I think we certainly get the direction in which things are being, I think, overall regulated in terms of reimbursement. And I think, again, it's up to our field to produce the randomized trials that will allow us to really understand and expand those indications.
I think you hit upon all the key points. I mean, we now have an option that procedurally allows us to reduce that embolic risk in patients who are admittedly rather narrowly defined, but are an important group of patients, those who for some reason cannot take an oral anticoagulant safely long term, although there's a need to bridge it. And we've got to address the economic things because at this particular point there's a lot of variation in how it is covered. And I like what you said about the learning curve. I think most of the things we do, we remember the early defibrillator days and the ablation days, and our surgical colleagues remember their stuff. There's always a learning curve with these procedures, but clearly those institutions, I would argue, committed to doing it well, committed to getting people, comfortable with it, et cetera. They're going to do it well, and then the complication rate will be lower. And all the studies demonstrate that. The original work showed a higher complication rate that substantially was lower as we got more experience at different institutions. So I think you're absolutely, right on where that is. How do you engage your own team at Stanford in how you do this? Choosing the patients, looking at the anatomy, the imaging considerations, all those enter into getting an appropriate, closure. Because clearly a bad closure where there's leak could augment the risk rather than lower the risk. So how do you guys do it at your institution? What would you recommend to physicians at their institutions as they start embarking in this road?
Yes. I think this is a great question. I think we have a tremendous opportunity in our field to be able to embrace a multidisciplinary approach. So at most institutions, including ours, it's a multi-pronged approach. Interventionalists, electrophysiologists, imaging experts, they all come together really to select the right patients, make sure they're evaluated appropriately, et cetera. And so I think we've maintained, I think, a very significant focus on those elements. so that exactly as you said, not only do we perform the procedure well, but we select the patients well. So I think those are critical take-home messages for our audience. No, it's been great to talk to you about this important topic. I think, again, more data are the things that we want to learn about. Again, I think in the future, other agents that are going to be developed, both pharmacologically and in devices, I think will lead us to really a whole new plane of being able to treat effectively and prevent stroke and atrial fibrillation.
I think you're right. It's an exciting time. We have a great opportunity to advance the care of our patients. Great. Paul, thank you very much for being with us, and thank you all for watching. We appreciate it. Have a good day.